Hello, dear student. My congratulations with starting new semester, and I hope you have a lot of energy for successful studying. So we are continue gastroenterology track, and for today's topic is chronic pancreatitis. And please don't forget leave your name and number of group under the video. So start, yeah? What is chronic pancreatitis? Chronic pancreatitis is a progressive, disabling fibroinflammatory disease of the pancreas of variable clinical course and is usually associated with permanent loss of exocrine and endocrine function over a period of time. What about pancreatic anatomy? The pancreas is an oblong-shaped organ positioned at the level of the transpyloric plane and with the excretion of the tail of the pancreas is a retroperitoneal organ located deep within the upper abdomen in the epigastrium and left hypochondrial regions. And pancreas consists of 5 parts, all divided of 5 parts. Head, the widest part of the pancreas, it lies within the C-shaped curve created by the duodenum and is connected to it by connective tissue. Next part, uncinate process, a projection arising from the lower part of the head and extending medially to lie beneath the body of the pancreas. It lies posterior to superior mesenteric vessels. Next is the neck. Located between the head and the body of the pancreas is it overlies the superior mesenteric vessels which form a group in posterior aspect. Next, body, centrally located, crossing the midline of the human body to lie behind the stomach and to the left of the superior mesenteric vessels. And tail, the left end of the pancreas that lies within close proximity to the hilum of the spleen. It is contained within the splenorenal ligament with the splenic vessels. This is the only part of the pancreas that is intraperitoneal. The pancreatic duct runs the length of the pancreas and unites within the common bile duct, forming the hepatopancreatic ampulla or water. This structure then opens into the duodenum via the myo-duodenal papilla. And on this picture you may see anatomy of pancreas. And what about pancreatic physiology? Consists on 2 parts, endocrine and exocrine. Exocrine 98% and endocrine 2%. And what about exocrine function? Exocrine pancreatic acinar cells produce digestive enzymes which are stored in the secretory granules. The pancreatic exocrine secretion is regulated by cephalic, gastric, and intestinal stimuli. Acinar cells secrete pancreatic juice made up the enzymes amylase, carbonate digestion, lipase, lipid digestion after bile has emulsified the fat, and proteases, protein digestion. An exocrine section is stimulated by vagus nerve, secretin is hormone, and cholecystokinin. And what about endocrine function? Isthmus of Langerhans, clusters of hormone-producing cells secreted directly into circulation. Endocrine cells of the pancreas. Beta cells produce insulin, alpha cells produce glucagon, and D cells produce somatostatin. And what about cells of pancreas? What secretion and what is function? Acinar cells secreting enzymes into the duodenum, and secretion nucleases, proteases, lipases, and amylase. And function for nucleases break down nucleotides, proteases digest proteins, lipases digest lipid, and amylase digest carbohydrates. And next cells are isthmus of Langerhans secrete hormones into the bloodstream. And what secretion? Glucagon with help alpha cells, and function stimulates glucose release into the bloodstream from glucose stores. And next cells, beta cells, and insulin, and increases cells uptake and storage of glucose. And last cells, delta cells, are somatostatin produced cells. And next about classification systems and what use classification. Which used classification? Manchester classification, ABC classification, MANNHEIM classification. Next classification, TIGARO classification, and Rosemont classification. And first classification is Manchester. The Manchester classification system uses imaging modalities and clinical signs of chronic pancreatitis. The degree of severity is mostly influenced by the presence of exocrine or endocrine insufficiency or the presence of complications, while imaging findings are of minor importance. The ABC classification recommends similar finding classification system. Different guidelines recommended using another classification with the name TIGARO classification. This system comprises 6 etiologic groups: toxic, metabolic, idiopathic, genetic, autoimmune, recurrent acute pancreatitis, and obstructive groups. And on this under text you may see table with detail every those etiologic factor, metabolic, idiopathic, genetic, autoimmune, recurrent and severe, acute and obstructive. And what about next? The Mannheim system is the only of offering a severity index and is used accordingly. Finally, after complex procedures, a score of between 0 to 25, representing the severity of chronic pancreatitis, is calculated. Yes, and clinical classification of pancreatitis, and have 3 categories: chronic pancreatitis, alcoholic, nutritional, and hereditary. Next, chronic idiopathic pancreatitis, juvenile, senile, and third variant, chronic obstructive pancreatitis. The course of the disease may be mild, moderate, and severe. Mild course characterized by rare and short-term exacerbation, not more than 1-2 times a year, which are quickly and easily stopped. No signs of functional pancreatic insufficiency. Body weight is not reduced. The patient's general condition is satisfactory. Next course, moderate, and manifestation 3-4 times a year, pain in more intense and long-lasting, pronounced phenomenon of enzymized deviation in blood, disorders of exocrine function, derangements of endocrine function are moderate and reversible. Weight loss during the disease attack, which is usually restored after relief. And severe course, frequent and prolonged exacerbations with persistent and severe pain and dyspeptic syndrome, with symptoms of maldigestion and malabsorption, typical pancreatic stool with steatorrhea, pancreatic diabetes, progressive emaciation of patient. And next, etiology of pancreatitis. The most common risk factor for pancreatitis is alcohol abuse, with logarithmic risk increased, although the type of alcohol consumed is irrelevant. Some authors suggest at least 80 grams a day for a period of at least 6 years. Smoking is most probably an independent risk factor, since smoking leads to the progression of chronic pancreatitis, and all patients should be advised to stop smoking. Genetic factors also contribute to pancreatitis development. The most important genetic risk factors are variants in cationic trypsinogen, a serine protease inhibitor called type 1, and carboxypeptidase A1. Further genetic susceptibility genes and asystolic fibrosis, transmembrane conductance regulator, hemotrypsinogen C, and carboxyacetylase, and additionally autoimmune processes can lead to the development of pancreatitis. And cholecystolithiasis and or choledocholithiasis alone are not considered risk factor for development of pancreatitis. Protective environmental factors haven't been described, whether anatomic anomalies such as pancreas division increase the pancreatitis risk is still a matter of debate. Obstructive pancreatitis develops as a secondary complication. A diagnosis of cystic fibrosis needs to be ruled out in all patients with pancreatitis onset before the age of 20 years, as well as patients with so-called idiopathic pancreatitis. Depending on the etiology, pancreatitis has different disease courses and long-term complications. Epidemiological studies have shown that calcification and endocrine insufficiency develop after a shorter time period in alcoholic pancreatitis patients compared to other etiologies. Although causal treatment options for alcoholic pancreatitis are currently not available, cessation of alcohol consumption may reduce the rate of progression, decrease pancreatic pain, and partly restore pancreatic endocrine function. In patients with genetic predisposition, the age of onset is generally earlier, and exocrine and endocrine insufficiency are more prevalent compared to other etiologies. Patients with inherited chronic pancreatitis seem to have a higher risk of developing pancreatic adenocarcinoma. Most likely, the early onset of the disease in these patients and the longer disease course are the main reasons for an increased risk of developing pancreatic cancer. And finally, recent studies have demonstrated the interaction on different genetic risk factors with each other, or the interaction of other risk factors such as pancreas division with genetic variation might increase the risk of developing chronic pancreatitis. Yes, and next chapter of our lecture is pathophysiology. And chronic pancreatitis is a disease process characterized by irreversible damage to the pancreas as distinct from the reversible change noted in acute pancreatitis. The events that initiate and then perpetuate the inflammatory process in the pancreas are becoming more clearly understood. Irrespective of the mechanism of injury, it is becoming apparent that stellate cells activation that results in cytokine expression and production of extracellular matrix proteins cause acute and chronic inflammation and collagen deposition in the pancreas. Though the condition is defined by the presence of histologic abnormalities, include chronic inflammation, fibrosis, and progressive destruction of both exocrine and endocrine tissue. And chronic pancreatitis is characterized as progressive fibrotic destruction of the granular tissue. The secretory parenchyma is destroyed by processes such as necrosis or apoptosis or both inflammation or duct obstruction. Increasing evidence indicates that pancreatic stellate cells, or PSC, are the major mediators of fibrosis, resulting in the formation of extracellular matrix, or ECM, in the interstitial space and in the areas where acinar cells disappear or duct cells are injured. This process ultimately leads to the progressive loss of the lobar morphology and structure of the pancreas and deformation of the large duct and severe change in the arrangement and composition of islets. The fibrotic destruction of the pancreatic gland is irreversible, and the morphological and structural changes lead to functional impairment of both exocrine and endocrine function, and may leading to malnutrition and diabetes. The exact pathophysiological mechanism initiating and maintaining the development of fibrosis in the pancreas are poorly understood, but may be viewed as a progression similar, for example, liver fibrosis, and hence the initial injury to one or all of the various tissue compartments or cell type of pancreas lead to cell necrosis and or apoptosis and consequently release of cytokines growth factor. As from immigrating inflammatory cells, especially macrophages and or nearly pre-existent epithelium or mesenchymal cells. And therefore damaged cells are phagocytosis by macrophages, causing release of cytokines, which in turn causes activation and proliferation of resident fibroblast or PCS or pancreatic stellate cells situated in the immediate surrounding of the original site of injury, which accordingly induce transformation in into fibroblast cells. And clinical features of chronic pancreatitis. Patients with chronic pancreatitis seek medical attention predominantly because of two symptoms: abdominal pain or maldigestion and weight loss. Clinically, the patient experiences intermittent attacks of severe pain, often in the mid-abdomen or left upper abdomen, and occasionally radiating in a band-like fashion or localized to the mid-back. The pain may occur either after meal or independently of meals, but is not fleeting or transient or tends to last at least several hours. Unfortunately, patients often are symptomatic for years before the diagnosis is established. The average time from the onset of symptoms until a diagnosis of chronic pancreatitis is 62 months. The delay in diagnosis is even longer in people without alcoholism. The natural history of pain in chronic pancreatitis is highly variable. Most patients experience intermittent attacks of pain at unpredictable intervals, while a minority of patients experience chronic pain. In most patients, pain severity decreases or resolves over 25 years. Other symptoms associated with chronic pancreatitis include diarrhea, weight loss. This may be due either to fear of eating or due to pancreatic exocrine insufficiency and steatorrhea. And what about main symptoms in patients with chronic pancreatitis about pain? Abdominal pain is the most significant symptoms and a major clinical challenge in chronic pancreatitis. And it's present in up to 90% of the patient and primary cause of hospitalization. Pancreatic pain is characteristically described as a constant, severe, dull epigastric pain that often radiates to the back and typically warns after high-fat meals. However, many different pain patterns have been described, ranging from the pain to recurrent episodes of pain and pain-free intervals, to constant pain with cluster of severe exacerbations. Lesion to intrapancreatic nerves and the impact of the pathogenesis of pain in pancreatitis. Pancreatic duct hypertension, pain due to complication to the disease, is also likely to contribute an adverse effects. To treatment must not be overlooked as an additional course of pain. And next symptom, is maldigestion. And what is maldigestion? Yeah, maldigestion in manifestate as chronic diarrhea, steatorrhea, weight loss, fatigue, seldom vomiting, nausea. And patients with chronic abdominal pain may or may not progress to maldigestion. And 20% of patients will present with symptoms of maldigestion without a history of abdominal pain. Physical findings in this patient are usually unimpressive, so that there is a disparity between the severity of abdominal pain and the physical signs that usually consist of some mild tenderness. During an attack, patient may assume a characteristic position is an attempt to relieve the abdominal pain. Occasionally, a tender fullness of mass may be palpated in the epigastrium, suggesting the presence of a pseudocyst or an inflammatory mass in the abdomen. Patients with advanced disease exhibit decreased subcutaneous fat, temporal wasting, sunken supraclavicular fossa, and other physical signs of malnutrition. And physical examination. On palpation of the abdomen, the following pain points and zone of determine. And on this picture you may see what zone and where patient feel pain. And first point, Shofart zone, but on the picture too, between the vertical line passing through the navel and the bisector of the angle formed by the vertical and horizontal lines passing through the navel. Pain or tenderness in this area is most typical for the localization of inflammation in the head of pancreas. Next area, Guber-Gritz-Kolsky area is similar to the Shofart area, but located on the left. Tenderness in this area is characteristic of inflammation in the area of the pancreatic body. Next point, first located. First on picture, on this picture, located 6 centimeters above the navel, along the line connecting the navel with the right armpit. And tenderness at the point is characteristic of the localization on inflammatory in the head of the pancreas. Next point, Guber-Gritz or catch point, to name of this point, similar to the point of the previous point, but located off the left. Tenderness of this point observed with inflammation of the tail of the pancreas. And this on your picture you may see number 4. And next, May-Robson point located of the body of the outer and middle third of the line connecting the navel and middle on the left costal arch. And tenderness of this point is characteristic of inflammation of tail the pancreas. And on this picture number 3. Yeah, and May-Robson's point. Yeah, continue about physical examination and the region of the costal vertebral angle of the left in painful with inflammation of the body and tail of the pancreas. With a long-term course of pancreatitis, a positive sign of growth is determined atrophy of the subcutaneous fatty tissue in the area of the projection of the pancreas in the anterior abdominal wall. Examination may reveal a symptom of the red droplets, the presence of the red spots of the skin of the abdomen, chest, back, as well as brown skin over the pancreas. Gray turning sign refers to bruising of the flanks, the part of the body between the last rib and the top of the hip. The bruising appears as a blue discoloration and is a sign of retroperitoneal hemorrhage or bleeding behind the peritoneum, which a lining of the abdominal cavity. And colon sign is hemorrhagic discoloration of the umbilical area due to intraperitoneal hemorrhage from any cause. One of the more frequent causes is acute hemorrhagic panniculitis. Gray tone sign is a discoloration of the left flank associated with acute hemorrhagic pancreatitis. And for example, of this picture you may see those different signs. Gray tone signs, colon signs, and growth sign. Next, approach consideration. And what about diagnosis? When you determine that your patient have pancreatitis. Test to establish the diagnosis. Ultrasound, computer tomography, abdominal X-ray, magnetic resonance, pancreatography, endoscopic ultrasound. Next, test of pancreatic function, collection of pure pancreatic juice after secretion injection, and fecal pancreatic elastase, and test of anatomy prior to surgery. And blood test. The diagnosis of early or mild chronic pancreatitis can be challenging because there is no biomarker of the disease. In contrast to acute pancreatitis, the serum amylase and lipase levels are usually not strikingly elevated in chronic pancreatitis. Elevation of serum bilirubin and alkaline phosphatase may indicate cholecystitis secondary to common bile duct stricture caused by chronic inflammation. May patient with impaired glucose tolerance with elevated fasting blood glucose levels, while lower concentration of serum trypsin are relatively specific for advanced chronic pancreatitis. They are not sensitive enough to be helpful in most patients with mild to moderate disease. Laboratory studies to identify causative factor of chronic pancreatitis include serum calcium and triglyceride levels. When common etiologies are not found, research protocols are available to test the genetic mutation in cationic trypsinogen. And fecal test. Because maldigestion and malabsorption do not occur until more than 90% of pancreas has been destroyed. Steatorrhea is a manifestation on advanced chronic pancreatitis. Neither qualitative qualitative fecal fat analysis can detect early disease. Assays of fecal hemotrypsin and human pancreatic elastase 1 the same limitation but are useful in confirming advanced chronic pancreatitis with exocrine insufficiency. This test allows to determine or to rule out pancreatic exocrine insufficiency and its degree. And what about pancreatic function test? Divided direct test and indirect test. And direct test determination in duodenoaspirates and determination in pancreatic juice. And non-invasive tests of pancreatic function have been developed for detecting chronic pancreatitis. And these tests work via oral administration of a complex substances that is hydrolyzed by a specific pancreatic enzyme to release a marker substances. The intestine absorbs the mica, which then is measured in the serum or urine. These tests are capable of detecting moderate to severe chronic pancreatitis, and presence of renal, intestinal, and liver disease may interfere with the accuracy of this test. And what is test? Respiratory pancreatic test. C. Triglycerides breath test, protein breath test with C marked white amylase, and neither currently is freely available. Three pancreatic test. And radiographic evaluation of a patient with suspected chronic pancreatitis usually proceeds from a non-invasive to more invasive approach. Abdominal computed tomography imaging is the initial modality of choice, followed by magnetic resonance imaging, endoscopic ultrasound, and pancreas function testing. Plain films show calcification due pancreatic lithiasis in 30% of affected patients. Generally, it manifests with a focal enlargement of a mass-like lesion of the pancreas, which is hypoenhancing. It may be associated with main pancreatic duct and common bile duct dilatation when localized as the pancreatic head, but they commonly tape smoothly and are not completely obstruct. Ultrasound evaluation. The pancreas might appear atrophic, calcified, or fibrotic, and findings that may be present on ultrasound include hyperechogenicity, pseudocysts, pseudoaneurysms, and presence of ascites. And ultrasound may also assist to differentiate between the autoimmune type versus acute. And next about computer tomography evaluation and future of chronic pancreatitis include dilatation of the main pancreatic duct, pancreatic calcification, change of pancreatic size, shape or contour, and pancreatic pseudocysts. Next, endoscopic retrograde cholangiopancreatography, and this method is the most sensitive imaging study for chronic pancreatitis and demonstrates irregularities of the pancreatic duct structure, calculi, dilated segment, and change in first and second order branch and cyst formation. And this method's help is showing extent of disease and useful for staging. One limitation of this method, however, is that it cannot be used to evaluate pancreatic parenchyma, and histologically proven chronic pancreatitis has been documented in the setting of normal finding on pancreatogram. And these methods provided with endoscope. Next method is magnetic resonance cholangiopancreatography. And this method provides and examine a pancreatic parenchyma and magnetic resonance cholangiopancreatography uses heavily T2 weighted images to visualize the biliary and pancreatic ductal system. The use of secretin during the study enhances the quality of the pancreatogram. And next, histologic finding of pancreatitis. In the early stages of chronic pancreatitis, the parenchyma exhibits an increase in connective tissue around the ducts and between the lobules. The degree of inflammation is minimal to moderate, consisting mostly of T lymphocytes and patchy focal process, and eventually affects the pancreas. With increasing severity, the connective tissue progresses between the acini, which gradually become distorted and tend to disappear. In advanced disease, fibrous tissue replaces the acinar tissue, and the pancreas becomes contracted, small, and hard. The effects of Langerhans are relatively shaped until very late in the disease process. And in chronic calcific pancreatitis, plaque of precipitated protein develop within the ductal system, while they may be observed in all types of chronic pancreatitis. In alcoholic and tropical form, 3 plaque tend to involve the calculi by deposition of calcium within them. The calcified pancreatic calculi are distributed irregularly. And diagnostic algorithm based on the new mechanistic definition of this. With clinical suspicion of disease, this algorithm suggests the concordance of 3 features: clinical, risk, and biomarkers. To make a diagnosis, and it divides the approach into levels of investigation. Once a diagnosis is made, then the progressive workup can focus on issues related to managing. Yes, and you may see clinical features, risk with classification TIGARO, and biomarkers. And in different combination, you may see different manifestation of pancreatitis. Manifestation, examination of pancreatitis. And after then you when you determine what is pancreatitis, what stage, and provide laboratory examination, provide instrumental examination. You may start and you can start and think about treatment. And what about treatment approaches? No correct treatment for chronic pancreatitis exists. Medical therapy is determined primarily by symptoms. If no anatomic explanation for abdominal pain can be found, medical therapy can be attempted. This therapy includes pain control with analgesic agents and trial on corn-coated pancreatic enzymes. The goals of medical treatment are the following: modify behaviors that may exacerbate the natural history of disease, enable the pancreas to heal itself, determine the cause of abdominal pain and elevate it, detect pancreatic exocrine insufficiency, and restore digestion and absorption to normal, and diagnose and treat endocrine insufficiency. Yes, and first part of your treatment is diet. A diet low in fat and high in protein and carbohydrates is recommended, especially in patients with steatorrhea. The degree of restriction depends on the severity of fat malabsorption. Generally, an intake of 20 grams a day or less is sufficient. Patients who continue to suffer from steatorrhea following fat restriction require medical therapy. Malabsorption of the fat soluble vitamins and vitamin B12 may also occur. Oral supplements of these enzymes is recommended. And you may see that patients with chronic pancreatitis must have several meals, and better 5 times a day with exact schedule, and total calories must be 1,500 calories. And this diet must contain total fat, calcium, sodium, carbohydrates, protein, and iron for every day, for every week, and all life for this patient. Next step in treatment of pancreatitis is management of pain. From the social point of view, patients with chronic pancreatitis who continue consume alcohol after appropriate patient education is still warranted and should be encouraged to stop alcohol use by means of counseling, attendance, and Alcoholics Anonymous, and all other programs. Urgent interventions should be performed in patients who continue to consume alcohol. In general, elective interventional procedures should be performed with caution in patients who are actively consuming alcohol. Patients with chronic pancreatitis often experience pain in the setting of a pancreatic duct obstruction. Endoscopic decompressive produced, including pancreatography with pancreatic sphincterotomy, stone clearance, stricture dilatation, and pancreatic duct stenting. Other endoscopic options include interventional procedures that usually involve placement of a transluminal stent to allow pancreatic duct decompression. And management of pain may contain antioxidant therapy, and antioxidant therapy has a benefit of treating pain. An exact mechanism by which these agents could reduce pain is not fully clear. Most theories propose that these agents reduce oxidative stress and provide an inflammatory effect. And if these agents were helpful, they could potentially be used as an alternative to other medication, including narcotics. Opiates may be considered to treat painful pancreatitis only in patients in whom all other reasonable therapeutic options have been exhausted. If a patient is unable to be palliated with other modalities, then opiates are justified for refractory pain. Patients who have been previously prescribed opiates for pancreatitis should be encouraged to transition to other medication. The impetus for using exogenous pancreatic enzymes to reduce pain begins the hypothesis that stimulation of the pancreas by food causes pain. Cholecystokinin is one of the possible mediators of this response, and cholecystokinin releasing factor typically is secreted in the duodenum. During the interdigestive period, proteolytic enzymes within the pancreatic juice rapidly degrade release factor. After a meal, the proteolytic enzymes are occupied with digesting dietary proteins, and enough releasing factor escapes to bind to duodenocytes, which stimulate cholecystokinin releasing factor. Is in turn stimulated pancreatic secretion. In severe chronic pancreatitis with exocrine insufficiency, cholecystokinin level may be high because proteolytic enzymes are low. When pancreatic enzyme supplements are administered in high dose, degradation of releasing factor is restored and the stimulus for cholecystokinin release is reduced. When exogenous pancreatic enzymes are taken with a meal, cholecystokinin releasing factor are degraded and cholecystokinin release in response to meal is reduced and indicated the smaller cholecystokinin response. This decreases pancreatic stimulation and pain. Not all gastroenterology societies suggest the use of pancreatic enzyme supplements to improve pain in chronic pancreatitis. And salic plexus blockade refers to the injection of pharmaceutical into and all around the region of the salic ganglia. Advantages of salic plexus blockade include the fact that a single treatment can potentially provide pain reduction or relief for 3-4 months, may reduce or eliminate the need for oral analgesia and can be performed quickly and repeat as needed. Next step in treatment, pharmacological restoration of digestion and absorption. And patient with pancreatitis should have periodic evaluation for malnutrition, including tests for osteoporosis and fat-soluble vitamin deficiency. The treatment of steatorrhea with pancreatic enzymes is straightforward, even though complete correction of steatorrhea is unusual. Enzyme therapy usually brings diarrhea under control and restores absorption of fat to an acceptable level and affects weight gain. The most widely used enzyme preparation is porcine pancreatine. The preparation contains a mixture of protease, lipase, and amylase. Pancreatic enzyme supplements improve fat absorption and hence reduce steatorrhea, and this may have beneficial effects of drug absorption. And on this table you may see name of this porcine pancreatine. Yeah. Creon with different doses, Zepium with different doses, and Pancrease with different doses too. Yeah, and different doses depend on stage. Yeah, stage and manifestation of chronic pancreatitis. Yeah, maybe mild stage, maybe moderate, maybe severe, and depend on this stage, depend and doses of pancreatine. And yes, some information, short information about what is autoimmune pancreatitis, and weight loss from pancreatic atrophy and new onset of diabetes may also occur in patients that smoke and consume alcohol. An obstructive pattern of liver test is common. Elevated serum level of immunoglobulin G4 provide a marker for the disease, particularly in Western population, is elevated in 2/3 of those with autoimmune pancreatitis. And computed tomography scans reveal abnormalities in the majority of patients and include diffuse enlargement, focal enlargement, and a distinct enlargement as the head of the pancreas. Endoscopic retrograde cholangiopatography of magnetic resonance cholangiopatographic reveals stricture in the bile duct in more than 1/3 of patients with autoimmune pancreatitis. This may include common bile duct strictures, intrahepatic bile duct strictures, or proximal bile duct strictures, with accompanying narrowing of the pancreas portion of the bile duct. These have been termed autoimmune immunoglobulin G4 cholangitis. Characteristic histologic Findings include extensive lymphoplasmatic infiltrate with dense fibrosis around pancreatic duct, as well as lymphoplasmatic infiltration resulting in an obliterative phlebitis. And Mayo Clinic HISORT criteria indicate that autoimmune pancreatitis can be diagnosed by the presence of at least one or more of the following: histology, imaging, serology, and other organ involvement and response of glucocorticoid therapy, with improvement in pancreatic and extrapancreatic manifestation. Glucocorticosteroids have shown efficacy in alleviating symptoms, decreasing the size of pancreas, and reversing histopathologic feature in patients with autoimmune pancreatitis. And patient may respond dramatically and peak dose of glucocorticosteroid within of 2-4 weeks, and used prednisolone with initial dose of 40 mg a day for a 4-week, followed for a taper of the daily dose of 5 grams a week, and monitoring clinical parameters. And some information about complication of chronic pancreatitis. And you may see on this picture, and what you may see here: rupture of pseudocyst, pancreatic ascites, pancreatic pleural fistula, dilated bile duct, portal vein thrombosis, intense inflammation on the heart of pancreas, obstructed dilated pancreas ducts, and similar complication. And most patients have impaired glucose tolerance, diabetic ketoacidosis, and diabetic coma are uncommon. And likewise, and organ damage, retinopathy, neuropathy, nephropathy is also uncommon. And difference between acute pancreatitis and chronic pancreatitis. The crucial difference one can make to tell the difference in the longevity of pain. Acute pancreatitis starts with a sudden attack of pain that patterns out after a few hours to days, while chronic pancreatitis remains persisting for a month. However, even then, the symptoms might not be reliable as it seems. For acute pancreatitis, diagnosis usually begins by looking at one medical history and physical examination and a blood test for enzymes in the pancreas. The blood amylase or lipase will usually be elevated 3 times the normal level and then would be a sign of acute pancreatitis. In some cases, blood doesn't elevate and other measures are taken to diagnosis, such as computed tomography scan. Chronic pancreatitis is more difficult to determine initially with blood test. Usually they are not used to diagnose it, but can determine how many pancreatic enzymes are in the blood. Yeah, and on this picture you may see a difference acute and chronic, and patient with chronic pancreatitis is acute pain and similar symptoms, and if patient have acute pancreatitis, this patient must visit hospital immediately, and with chronic pancreatitis, the patient may spend this pain at home without treatment, without drugs, and without visit hospital. So for today that's all. Thank you for your attention, and see you on next week with new topic of gastroenterology track. Goodbye and good luck.